good morning. Welcome to the webinar entitled Incorporating the Sex and Gender Perspective in Health and Biomedical Research Content and Presentation of the Hipàtia Toolkit. My name is Paula Adam, and I am Director of Research at the Agency of Health Quality and Assessment of Catalonia, and I have the pleasure to present this webinar today with our experts. I would like to mention that this webinar is organized by the Hipàtia of Alexandria Community of Practice, which was created after the celebration of the first summit for gender equality and leadership in the biomedical research centers of Catalonia, and that was in October 2019. As a result of this summit, the 20 directors of the 20 research institutes on health science that exist in Catalonia signed a charter of commitment, and a community of practice was created with an intense agenda. I should say that today is the culmination of the first part of the work of this community of practice with the current seminar, but there are other activities that will be going on during this year, and the culmination of these activities will be a second summit for gender equality and female leadership in biomedical sciences. These activities that I'm presenting are part of the implementation of the Strategic Plan of Health Research in Catalonia, the PERIS, promoted by the government of Catalonia. I will, in a minute, introduce our speakers. I would like to mention that the seminar, that you have a Q&A box where you can write your questions, and I will be taking notes of it. And at the end of the seminar, after our two experts will have a lively Q&A session. Also, as a reminder, the hashtag for this conference is Jo soc Hipàtia in Catalan. And now I'm just turning to present our first speaker, which is Londa Schiebinger. Londa is the John Hinds Professor of History of Science at Stanford University and founding director of Gendered Innovations in Science, Health, Medicine, Engineering, and Environment. Gendered Innovations harnesses the creative power of sex, gender, and intersectional analysis to enhance excellence and reproducibility in science. She's a leading international expert on gender in science and technology, and has addressed the United Nations, the European Parliament, the Korean National Assembly, and a numerous funding agencies on the topic. Schiebinger received her PhD from Harvard University and is an elected member of the American Academy of Arts and Science. She is the recipient of numerous prizes and awards, including the prestigious Alexander von Humboldt Research Prize and the Guggenheim Fellowship. So the title of the conference is Gendered Innovations in Health and Biomedicine, Analytical Puzzles and Next Steps. So I'll give the floor to Londa Schiebinger.
Thank you. Good morning from Stanford University. It's 8 o'clock in the morning here, so forgive me if I'm not quite awake, but I think I am. I'll begin by sharing slides that you can see here. There we are. Okay. So I'm very delighted to see your Hipàtia Toolkit. I looked through it, I read it this weekend. It's very good, and I look forward to it being presented later. And today I want to explore with you gendered innovations. We also provide methods and examples or case studies of sex, gender, and intersectional analysis in the design of research. Gendered Innovations was produced through a large international collaboration involving the European Commission, the National Science Foundation, and Stanford University. And we've now expanded into South Korea, South Africa, Japan, and Argentina, and other places. Gendered Innovations has brought together over 220 basic scientists and engineers across the European Union, Canada, and the US. And we also work with Silicon Valley industry leaders such as Google, Facebook, and the like. So innovation, as Paula said, is about integrating sex, gender, and intersectional analysis for discovery. Does considering gender add a valuable dimension to research? Does it take research in new directions? Now, we know why this is important to your research. Beginning in 2020, the European Commission's Horizon Europe strengthened their gender dimension in research requirement. You are now required to integrate sex and gender and sometimes intersectional factors in your research, or you need to justify that it's not relevant to your work. To support this policy, the EC convened a 2-year expert group, which I directed and which Sabine was also part of. And this group consisted of 25 experts from numerous fields of science, medicine, and technology. Our results are published here and also on the Gendered Innovations website. They're easily downloadable. Everything is free and you can have a look. Now, the US National Institutes of Health also has similar policies. In 2016, the NIH implemented its requirement that sex as a biological variable must be included in all publicly funded research. The idea is that if taxpayer money is being used, research should benefit everyone across all of society and not just a privileged few. The NIH is now considering a policy on gender as a sociocultural variable. We published a paper on that in 2021, and there is a workshop this fall to address this particular topic. So it's crucially important to get the research right from the very beginning. And I see your toolkit also stresses that. And this is the goal of Gendered Innovations. We develop state-of-the-art methods of sex, gender, and intersectional analysis and provide case studies to illustrate how gender analysis leads to discovery and innovation. And in this talk, I will discuss some of these case studies with you. One of the most important things you can do in your research is use the word sex and gender correctly. I can't believe it's 2022 and I still have to say this. Sadly, medical researchers, well, many researchers often confuse these terms, which makes meta-analysis difficult. So here's a really nice paper and you can read why it's important and you can see what the story is. So now let me get into some details. And of course, we have to remember that sex and gender interact. This is a very nice image from Vera Regetsa-Gorosek, which shows that from conception, sex or the biological characteristics of a human, maybe genes, sex hormones, interact with all the social factors in your life. It could be gender, it could be nutrition, it could be education, it could be economic, socioeconomic status, lifestyle. These interact over the course of a lifetime to make you, to give you your health status as an adult. Now, today I want to discuss how sex and sex interact. I will also discuss how sex and gender interact, and I will discuss intersectional analysis and gender-related variables in health research. So I'll start with animal research. Animal research often excludes female animals because they are thought to be more variable. The idea is that the estrous cycle means that females are more variable than males. But this well-known article from Brian Prendergast shows that this is incorrect. Prendergast shows that randomly cycling female mice are no more variable than males on any trait. So researchers can include male and female mice without controlling for the estrous cycle. This is now considered best practices. But in some instances, especially when treating female diseases, taking the estrus, or in humans, menstrual cycle, into account is crucial to the success of the treatment. So let me give you an example from nanomedicine, and specifically the use of chemotherapeutic nanoparticles delivered intravenously to treat uterine and breast cancer. This is a new study from Ari Schroeder's lab and shows that in mice, the female estrous cycle affects how nanoparticles are distributed in the body. So during ovulation, these nanoparticles are twice as likely to accumulate in the ovaries, and this enhances the treatment for ovarian cancer. However, these treatments then don't work very well for breast cancer because the nanoparticles are accumulating in the ovaries and do not reach the tumors in the breast. So this is a complex topic, and I recommend that you read the paper. But there may well be many instances where the menstrual cycle should be studied for medical interventions. It's important when analyzing sex to consider the life stage or the age. We need to consider potential pregnancy. As the head of the Canadian Institutes of Gender Health often says, sick women get pregnant and pregnant women get sick. So we need to know something about that. And also we need to look at the menstrual cycle. This is all part of analyzing sex. Now, if I go on in animal research, I want to see again, this time how sex and sex interact. And this example is from a Canadian group in Jeff Mogul's lab. And it looks at the relationship between the sex of the animal and the sex of the researcher. So now that the NIH has this requirement that you have to look at sex as a biological variable in all biomedical and public health research, we want to know what the sex differences are from the treatment. But the conditions in the lab may also impact the biological characteristics of the animal. And we may see sex differences where it really is just a lab condition. So we know caging is an issue, we know diet, we know room temperature, but I want to look at this relationship between the sex of the researcher and the sex of the animal. So this example focuses on pain research. The researcher induces pain in mice and rats. They're studying pain, and what they found was amazing. They found that the mice don't show their pain to men researchers. And this is what they're studying. They want to know when the animal is in pain, but if it's a man in the room, the animal will not show its pain. The animals show their pain to women in the room, to the female researchers. So then the researchers tried all kinds of conditions. They wanted to know if it's just something in the room. They put a chair in the room, but they found it was specifically a man in the room. And they identified this as the male observer effect. So what's going on? It's not how the researcher handles the animal. It's that the animal smells the man. They smell the male pheromones. So according to Jeff Mogul, whose lab this came out of, this phenomenon may throw into question all prior results from pain research that started with animal models. Okay, now let me give you an example of how important analyzing sex can be. And here I want to look at sex at the cellular level and specifically consider X inactivation in females. So here's an example from the future. Maybe we are bioprinting organs one day. So let's say in the next decade or two, you're going to bioprint a kidney for organ transplant. You will need to know about the sex differences in the kidney and in the cells. And in this bioprinting process, the goal is to seed a frame with the patient's own cells to avoid rejection. But if the patient is female, you have to decide which of the X inactivated chromosomes should be used, or which activated one. And because of the complex X inactivation in females, the 3D bioprint graph will never be an exact copy of the original kidney, which of course is the goal. Okay, so far I've been talking about sex and how sex and sex interacts and various things, but now I want to discuss gender. Importantly, as I showed before, sex and gender interact, and let's see how that works in studies of pain. So pain, we know, has both biological aspects and cultural aspects, so gender differences in how people report pain and how patients understand and treat pain, or how physicians understand and treat pain in patients. So for the biology, here is the story in one simple chart. We see that there are male and female differences in the biology of pain. So researchers were looking for what mediates the pain in the brain, and they studied male mice, and they found that the microglia is the big story. And then the researchers thought to themselves, oh, we didn't look at any females, we better look at the female. So then they looked at the female pathway, and they found the big story is T cells, not microglia. So we could say there are what we might call male and female pathways of pain. However, it's not that simple. Males who lack testosterone, or let's just say older males, can cross over to this female pathway. And females who are pregnant, for instance, can pass over to this more male pathway. So none of this sex is never as binary as we tend to think it is. But then it's way more complicated than that once we add the cultural aspects. Pain has cultural aspects. Gender factors into how people report their pain. So here we have a patient. It can be a man, woman, a gender diverse, non-binary person. They have pain signaling. So they have real sex characteristics of pain, but they also are impacted by gender norms of how they report that pain to the physician. Now, the physician can be a man, woman, or a non-binary person, and there is an interaction between the patient and the physician, which may impact the gender norms of how the person expresses their pain. So we know that in many cultures, men are expected to be strong and resolute, and it's a cultural norm that they do not express their pain, and it's thought that women express their pain more. So we have these gender norms, and they're different for every culture. And of course, there are also ethnicity and other social factors that influence the expression of pain here. So this person has expressed their pain within their cultural norms. Then the physician hears the pain, and this person, whoever they might be, is influenced by gender stereotypes and behaviors as well. And in the end, this influences the treatment. Clinicians often perceive women's pain as psychological, and consequently, women receive more non-specific diagnoses, they wait longer for treatment, and they receive more antidepressant drugs instead of painkillers than do men. So we see that what treatment a patient receives depends on the patient's gender, the physician's gender assumptions, and then this all comes back to the health state of the patient. So we see that it's very important to study sex as a biological variable across the lifespan. And this is so important that Lancet requires, these are its requirements for sex and gender reporting, very important. And I should say that Nature has just upped its sex and gender reporting as for 4 basically medical journals. This is new, beginning this month in June. So they're also studying to see what impact those new guidelines have. So now let's move on to medical devices, and I want to talk about intersectional analysis. So pulse oximeters don't accurately report oxygen saturation levels in patients with darker skin. We in the US learned this the hard way during the pandemic. So we see there was an analysis of 47,000 readings, and they found that oximeters misread blood gases 12% of the time in patients with darker skin, and only 4% of the time in patients with lighter skin. This is because the infrared light that shines through the finger with the pulse oximeter sees both the deoxygenated hemoglobin, but it also sees the pigment in the skin. So it's confused by the pigment, and and the readings don't take into account extra pigment in the skin. This means that those patients who get misreadings may not get the supplemental oxygen they need to avoid organ damage. So this has been known since 1989, but not corrected. And in the course of my research, I found 2 patents in the 90s to correct this situation, but it just wasn't on anyone's radar. But now we have to say, are there other factors? What about sex? So we see that pigmentation, so darker skin is an issue. We might call that race, but what about sex? Do we need an intersectional analysis here? So what is intersectionality? Intersectionality is the intersection of any of these factors. Here it's race and sex. I see I don't have sex on my thing, but it could be ethnicity and age. It could be disabilities and language. It can be any of these things. So intersectionality is a term coined in 1989 by Kimberly Crenshaw, a legal scholar, to describe overlapping and intersecting forms of discrimination related to gender, sex, ethnicity, sexual orientation. We cannot consider sex in isolation. Sex intersects with many other important social factors. So returning to the pulse oximeter, ethnicity or skin tone may not be the whole story. There may also be different sex differences in pulse oximeter readings that have not been made a priority of research. So the findings, I went through everything, the findings are inconclusive. A 2007 study suggested that pulse oximeters don't work as well for women or anyone with smaller fingers. And from that 2020 study of 47,000 patients, I queried the author, who told me that he found a slight sex difference. It wasn't as much as the racial difference, but it was still a difference. So if we analyze how skin tone intersects with sex, we would see that women with darker skin would be most at risk. And much of what I said is also true of consumer wearables, the Apple Watch, the Fitbit, and other things that collect basic data. And basic data is being collected much more with these consumer wearables and then used as huge data sets and machine learning used to decide, basic treatment. So it's very important that these devices work for everyone so that the databases are not biased. Now for the public, and now I want to do my last example here. For the public researchers in the audience today, I wanted to present our study on gender-related variables for health research. I didn't find this so much in the Hipàtia Toolkit. We were trying to reduce something as complicated as gender to variables that could be manipulated quantitatively so that gender can more easily be included in clinical trials or in large public health studies. And we published this article after many years of agony, I have to say. It was incredibly difficult. So in this study, we developed theoretically robust gender-related variables for patient questionnaires. So we developed a questionnaire. Our instrument captures 3 dimensions of gender norms, gender identity, and gender relations. We started with a very large lit review from 1975 to 2020, reviewing over 6,000 articles. And we had a complex process of developing our questionnaire. This yielded 7 gender-related variables, which is what we then studied and used. So under the gender norms, we looked at caregiving strain, and we looked at occupation. Under gender identity, we looked at the element of independence, competition and risk-taking, emotional intelligence, and under gender relations, we looked at social support and discrimination. And just to make a long story short, this is a visualization of our results. You can see that for men, women, and gender fluid or non-binary, we have quite different results. For the non-binary, the discrimination is the hugest issue and the greatest health burden that they have. And you see that women suffer from discrimination more and men not so much. Men score high on risk-taking. So you can see how gender in this case can be an important variable when looking at people's health status. Now, I could give many more examples. I wanted to take you very quickly. I think I have just maybe a minute or two left. I wanted to take you very quickly to our website so that you can use it. It's free, open to the public. You can see the website, yeah? So we have lots of methods here. I'll show you, we have general methods and specific methods for tissues and cells, for lab animal research, for sex and biomedicine, gender and health and biomedicine, but general methods. And I wanted to show you, for example, analyzing sex. We emphasize that sex isn't just one thing. You don't add males and females and shake it up. You have to consider, and these are all the tips of how you do it. How do you identify your problem and what important aspects of sex do you need in your research? Then how do you design the research? And again, we have the latest research. All the citations are down here, or you can click the links. How do you design the research? What are the important things to consider when collecting data, analyzing data, and disseminating results? Because in disseminating results, it's as important to publish negative results as it is positive results of sex differences, because otherwise you get a very skewed picture of things. Then we have all of our case studies. The chronic pain that I was reporting on is here. We have heart disease in diverse populations, osteoporosis research in men, one place that men have been, not looked at carefully. Then we have what I wanted to end with is then the science infrastructure. And I've presented some of this already today. We know that, so these three pillars of the science infrastructure have to work together to bring about change. So I already reported on what funding agencies are doing, asking for sex and gender analysis before they offer grants. I reported on what peer-reviewed journals are doing at the end of the process. They're looking for quality in manuscripts by having guidelines for sex and gender, and now they will have them also for diversity. Nature is in the process of developing guidelines for diversity, but we are mostly in universities and we are not doing our job. So we don't need special seminars like this. All of this material should be included in the regular university curriculum. And I have for each of these then what I know about it. So we don't have as much for the curriculum as we have for others. So in health and medicine, we have these examples. I think Charité in Berlin was one of the few medical schools that really successfully integrated sex and gender analysis through their 6 years of medical training. We've been trying here at Stanford, but every time I try to get something more in the curriculum, the Nobel Prize winners, and I'll let you think about who those are, the Nobel Prize winners say, no, the students need more chemistry. So, I mean, so we're still fighting our battle over here. Yale has done some interesting things. So I'm saying this is one place where we need to work to solve this problem in a fundamental fashion so that we don't have to have seminars at 8 o'clock in the morning. Okay, so I will stop there and I thank you for your attention. You're muted, Paula.
Thank you very much, Londa, for this very, very interesting presentation. I should remind the audience that there is a Q&A section where you can put your questions or your comments, and at the end of the second speaker, we will make a lively discussion. So I'm going to introduce now to our second expert today, Sabine Oertelt-Prigione. She is a physician, researcher, organizational consultant, and coach. She's chair of the Gender in Primary and Transmural Care at the Radboud University in Nijmegen in the Netherlands and professor of sex and gender sensitive medicine at the University of Bielefeld in Germany. She has focused on different aspects of sex and gender differences in health, spanning from sex differences in autoimmunity to gender differences in cardiovascular diseases and sexual harassment in academia. Her current focus is in the implementation of sex and gender-sensitive research through the analysis of practices, development and methods, and engagement of the stakeholders. Next to her academic activities, she was member of the EU Commission's expert group Gendered Innovations, consults with the national governments and funding agencies in the implementation of sex and gender-sensitive healthcare and prevention of gender discrimination and harassment. So the title of her talk is the Operationalization of Sex and Gender-Sensitive Research in Health and Biomedical Research.
Well, thank you very much for the kind introduction. Well, I'm very happy to give this talk together with Londa. We've done it once before. It was a great experience. I have one or two slides that are the same, but pretty much I'm building on what Professor Schiebinger said before me. And I will just skip the slides where we have double things, but there's also one or two that I really think should be emphasized more than once, and so I'll just briefly point these out. Now, as was already said in the introduction, my background is in medicine and public health, so I have a slightly different perspective here. And I will try to walk you a little bit more through the practicalities. What is it that we're actually trying to measure? How can we do this in medicine? Or, in some cases, we don't know exactly yet. There's still some steps to be taken, but we have enough materials to start with and enough to definitely comply with the requirement to start studying this so that then we can develop it throughout the years. Now, what will I be talking about? Well, first of all, just a brief reminder of why we should consider the gender dimension. The EU Commission has already been mentioned, but I would like to point out a few aspects here. I will then talk a little bit more in detail about the operationalization of sex in biomedicine. How can we be doing it? What is happening? What you should consider, especially when you do basic research, which kind of elements should be taken into consideration. I will then talk a little bit about the operationalization of gender in biomedicine. This is an evolving field with more and more materials and different opportunities coming up to measure gender. It's definitely been something that evolved over the last 5 to 10 years. So it's a field we are paying more attention to. I then have a few examples of what can go wrong if you don't do it. So if I haven't convinced you before, I hope that these will do the trick. And then I have a few last thoughts about the connection between content and context when we do research. So moving back to Horizon 2020 and Horizon Europe for a second, or actually the funding agencies overall, you've already seen in the talk before that there is a strong commitment of at least some national and international funding agencies to this. But I really wanted to highlight what the topics are that are connected to focusing on sex and gender. And here I think it's really interesting to look at the own words of these different agencies. So if you look at Europe, of the European Commission, they say that you should include the gender dimension, as it's called in the European Commission, to improve the scientific quality and societal relevance of your work. The Institute of Gender and Health from the Canadian Institutes of Health Research will tell you that it improves the rigor, the reproducibility, and the generalizability of your work. And the US NIH will tell you that it enhances reproducibility through rigor and transparency. So we're not talking small goals here. We're talking about really relevant aspects when it comes to our research practice. So we have been discussing the reproducibility crisis in the last decades. And here the agencies tell you that this can actually help improve reproducibility. We're talking about excellence of research, so we would ideally like to do the best we possibly can, including state-of-the-art methodology. And what is often not taken as a first priority is the societal value of the work we do. Ideally, we would like to provide information, data, and possibly improvements for the health of everybody we are trying to care for. So if I don't convince you, I think the funding agencies have put it in really good words. What is then interesting, and this is going to be a bit of the division I'd like to pick up in my talk today as well, is that throughout Horizon 2020 and Horizon Europe at the European Commission level, the Commission addresses 3 layers. So what they talk about is fostering the gender balance in research teams, about ensuring gender balance in decision making, and about integrating sex and gender analysis. So this is the content dimension. So what they're really telling us is that there's 2 levels that work in concert, that work together. One is the context layer, which is the gender balance in the research teams. So you would like ideally to have a representation of women, men, and we don't even talk about gender diverse individuals yet. And of course, you want to have a gender balance in decision making. So having all male PIs and all female master students doesn't count. So it is really about who's sitting at the table and who gets to make decisions about which kind of research we're doing. And then, of course, there's the content part, which is what we're mostly focusing on today, which is the methodology. Now, I will start focusing on this mostly, and I'll say a few things about the context at the end. Now, as you've already heard in the talk before, when we look at sex and gender, what we do in the biomedical field many times when we do research is we try, at least if we use the terminology properly, to disentangle the effect of the two. So a lot of times we separate out sex-specific research and gender-specific research. What that means is in the field of sex-specific research, we focus on mostly these 3 elements, and I'll go more into detail of that afterwards. So genetics, hormones, and genitalia as ways to define sex. And then when we look at gender, the 3 big dimensions we usually look into are at least gender identity, gender norms, and gender relations. We've already heard a little bit about that before. I'll pick that up again later on. So let's start with the operationalization of sex in terms of these 3 Gs. Now, the first one, and probably the one that is mostly seen as a binary construct, is genetics. So individuals are usually XX or XY. However, the world cannot be divided neatly into a 50-50 division. Not everybody's XX and not everybody's XY. And although of all these markers, this is the probably most binary one that allows us to do 2 relatively homogeneous groups if we only look at these chromosomes, there are a number of people that don't fit into these groups because they either have only one X chromosome or they have multiple copies of the X chromosome. And although the prevalence is low, if you think in big terms, it is not that small of a population. But I would like to point you towards an even more relevant aspect. So what we've seen in the last decades, studying the evolution of our peripheral cells, so for example, circulating blood cells or rapidly reproducing cells such as fibroblasts, is that with the aging process, we tend to increase the number of monosomic cells in our blood. So it is well possible that individuals above 60, about 70, have a non-indifferent number of cells that only have an X chromosome and sometimes even only have a Y chromosome in their blood. So when we study this, and this has been mostly done in the field of autoimmunity, it turns out that as we age, some of our cells will become naturally monosomic. And this can be associated with disease, but it doesn't have to, because the clear connection here has not been established yet. But that already tells us that as our bodies change, also our genetics might change over time, and hence the binary might not be relevant for all cells if you're studying them. It might be worthwhile to have a look at what the karyotype of the person you're investigating or of the tissue of the person you're investigating looks like. Taking a second step, we go towards the gonads or the hormones. And here things already start becoming a bit more complicated, because there are many potential hormones that we can measure. We can start with the most bioactive one, which would be estradiol. We can measure the most abundant one, which is estriol. We can measure progesterone. We can measure testosterone or its precursors. And interestingly enough, we should always remember that apart from some exceptions of people that don't produce some hormones, all of us have all of these hormones. We just have them in different concentrations. And these concentrations change throughout the day, throughout the month, and throughout our lives. And that doesn't just go for women, because usually the first thing that comes to mind is a menstrual cycle. If we look at testosterone levels, for example, they're different in the morning and in the evening. So these hormones do change throughout the day. And if you want to measure them, you might have to think carefully about when the ideal moment is, or if you do multiple measurements, which might be needed, when these measurements should take place. And most importantly, sexual hormones, as we call them, it might be a bit of a deceptive term because these hormones are not just correlated to secondary sexual characteristics. They actually matter to pretty much all cells in our body. And this here is an example from the immunology field. If we look at the change of hormones throughout the menstrual cycle, so in the follicular phase, we have a higher concentration of estrogen. In the luteal phase, we have a higher concentration of progesterone. And these two hormones have an impact on the type of T-cell response that we will see in individuals exposed to these hormones in different phases of the menstrual cycle. So maybe you're really not interested in looking at hormones at all or looking at sex differences. But if you're studying the T-cell response and you're studying individuals that have a menstrual cycle, this might be something to take into consideration because maybe it's not the cells that do something different. Maybe it's just a different moment of the cycle when these cells have been analyzed. The third part, and I would argue this is how most of us have been attributed to one sex or the other at birth, is by looking at the anatomy of our genitalia. So what usually happens, the baby is born, the baby is inspected, we look at the genitals of the child and we attribute it to either female or male sex. Now, that works for most babies, but it doesn't work for all of them because there's a number of children that are born with genitals that cannot be clearly attributed to one sex or the other. And it is also true that in some individuals, the externally visible genital does not necessarily match the internal genitals. So depending on the statistics we look at, and here we really have quite different number depending also on the definition, going from 0.05 to up to 2%, the number of individuals with differences in sex development can be quite relevant in the population. The problem is we usually don't study this systematically, so in many cases we don't really know what the prevalence is. And is this really such a rare phenomenon in the animal kingdom? I put a mole here because moles are really nice animals, but also because moles are an example of naturally intersex individuals, or animals in this case. And because the female mole always, although she's fertile, has testicular tissue in her womb. And this testicular tissue has the function to produce testosterone, so it's active, so that her muscles in her arms can grow so much that she can actually live under the earth. So it is really an adaptation to make sure that her body adapts to her environment. And this means that this is just an example of a mammal, of course, quite different from us, but still a mammal, that is naturally intersex. Now, let's move on to the practical aspects. What does that mean when you do analysis, when you look at cells, for example, when you do cell cultures? Well, first of all, I don't see you, so I don't see your reactions, but I usually like to ask what if you know the sex of your cell cultures. Some people know. I get a lot of embarrassed stares usually because this doesn't seem to be knowledge that is common to everybody working with cell cultures. Now, maybe when you go back to your lab, it would be worthwhile to investigate that. The second part is, as I said before, as we age, our karyotypes can change, but also cells that have been in culture for a long time do change their karyotype. So for example, this has been described quite well in the oncology field, where we know that, for example, the karyotype of most HeLa cell lines is not predictable unless you really measure it, because these cells have been available and in culture in different labs throughout the world for so long. And this goes for many, especially tumor cells that have been immortalized and have been in culture really long. So most likely the karyotype that you're expecting might not even be the one you're seeing in the cell. In addition to that, there are techniques that we're using more and more. For example, reprogramming, building of organoids, and all these new technologies to use human tissue to build artificial organs on a chip do have an impact, for example, on the X chromosome, because the reprogramming process is a process of demethylation and remethylation. And so through this process, you can potentially change the expression of genes on the X chromosome and potentially change the way the cell will behave once it is reprogrammed. We do have some idea about some media that might have an impact on how cells grow. Although this is not really an area of big investigation because people are really not looking that much into it. And then we do know that methylation, so epigenetics, can have a cross-generational effect. So it's quite possible that the influence on epigenetics that your ancestors have experienced is still somewhat imprinted on your genes. And if we manipulate the cells and these genes, we can have different effects that are somewhat unpredictable. There's still open questions when it comes to the hormones that we use in culture. So when we do study sex hormones, it is quite possible that synthetic or purified hormones have different effects. We have heard about that quite a bit when we looked at hormone therapy for postmenopausal women, because in the olden days we used purified equine hormones and now we use synthetic hormones that have quite different bioavailability and effects. This might well be true also in cells. We don't really know because we haven't studied it yet. And the intrinsic differences of growth patterns associated with media, we also don't really know. Now, this is an example. It's actually a quite nice summary on how you could potentially approach the investigation of sex differences, and that had been published by Frank Morvay-Jarvis in 2017 in Cell Metabolism. So if you want, you can have a look at that. What it basically shows you is how can you approach this systematically, starting really with the basics. So first of all, you should have a look if there is a difference in trait in the mice you're studying in this case. So this is for animal studies. If you do find a difference, the question in this case, for example, could be, is it due to ovarian estrogen? At that point, what you would have to do is you would have to take away the sources of this estrogen. So what you do is you do an ovarectomy. You do 3 groups. The first one is, of course, sham operated, it's your control. Then you would have a group with ovarectomy and a vehicle that's inactive, and you would have a group with ovarectomy and this estrogen to kind of replace the natural situation. At that point, you would look what happens with the trait. Does it change? And which of these has an effect or not? If we see that it is in fact connected to estrogen, the next question is which kind of receptor is relevant in this case, because estrogen doesn't have just one receptor, it actually has 3, alpha, beta, and G protein related one. You are lucky in this case because we do have knockout models for all of these receptors, so you could possibly test this in the knockout models, and at that point, the last question that would still be open is which kind of tissues are affected by this, because not all tissues might be affected in the equal way. So this is a potential way of going about of investigating estrogens. Londa already mentioned this, the fact that animals, first of all, are social beings that live in cages. We think that we control everything when we put them in cages. We think we control their diet, the room temperature, what they eat, what they drink, how many they are. But still, there are a lot of factors that could be related to sex differences. For example, diet. If you feed a soy-based chow to your animals, that's an estrogen mimetic. So that could act as estrogen. We know that depending on how many animals of the same sex you put in a cage, they behave differently. So the females tend to fight, for example, depends on the size. If you have a larger colony, they will develop some sort of social dynamic in the cage. So that could be seen as gender. That's another discussion to be had, but they develop a social dynamic in the group. When it comes to other things that seem potentially random, temperature, for example, we know from actually human studies that on average, women prefer a slightly higher temperature in office spaces than men. Is that true also for animals? Does that impact their well-being? We don't know. So it might well be that these potentially passive factors also have an impact and lead animals to behave slightly differently, as we've heard before. And then, of course, the impact of the researcher has been laid out beautifully in the talk before, so I'm not going to pick that up again. Now, since investigating sex is not that easy as it seems, let's move on to gender, just to make things a little bit more complicated. Now, as I said before, we have several dimensions that we can be looking into. And of course, the main difficulty when we think about this from a biomedical perspective is that gender is really a concept that has been developed in the social sciences. And historically, first of all, the philosophy we base our investigations on in biomedicine, in the social sciences, are different. And that also means that the methodology that's been using in the social sciences cannot be transferred one-to-one to medicine. So the difficulty here is how can we employ techniques that we use in biomedicine to try to grasp a concept which doesn't really fit in our usual type of research. Now, what we've been trying in the last decades, I would say, successfully to a certain degree, is to try to divide it into different dimensions. So to try to investigate the different layers of gender with separate questionnaires. And so we could investigate, for example, gender identity. We can investigate gender norms and roles. We can investigate gender relations. And all of this, as I said initially, it's a developing field. So it's quite interesting to see the discussions going on. I'm not going to be talking about institutional gender, which I would say is at a level that's somewhat higher than that what we're discussing today. But of course, we live in societies that have ingrained gender effects in the laws, in the organizations, in the institutions we confront. And so these are already present, but it goes a bit too far for today. And we can pick this up in the discussion. I would also say I skip this now, but in principle, gender is something you do and not something that you are. But what we do in medicine is actually we measure it as a fixed construct, which also makes things a bit more complex. But let's start with the things that could be done. Now, the first one is investigating gender identity. And as Londa mentioned initially, some things that still happen today, it has improved with the awareness about the differences between sex and gender. But what has happened historically is that these two terms have been conflated. So people have been talking about the gender of their cells or the gender of their animals because they didn't want to write sex in a paper, because that could be the act instead of the variable, and then the paper wouldn't be accepted, especially if it was written in the title. So what we do now is we at least know that it's two different constructs, and ideally for biomedical research, we would like to know about both of them. And so what can we do? Well, one approach, which is gaining more and more traction, it's being used by several institutions in the United States for statutory measurement. In the EU, some organizations are picking it up. I don't know what the situation in Spain is specifically, but I know in the Netherlands they're picking it up for some things. In Germany, they're discussing. So several statutory surveys done by public health agencies will start picking up this two-step approach. And what it does is it basically asks about your sex at birth. So what were you attributed at when you were born? As I said, most of us, people looked at our genitalia and said you're female or male. So this is the question. And you can answer with female, male, intersex, potentially a sex not listed here. And then, of course, you would like to know what you choose and prefer not to respond. And the other one is asking about gender identity, which is really the concept of gender we mostly hear about in the news. So most of the discussion about gender that we're seeing in mainstream media is about gender identity. The roles, the norms, the relation, all of that really isn't addressed that much. It's really a discussion that mostly revolves around identity. Identity is who we are. If you ask me, what do you identify as? Who are you? You can respond, I'm a woman, I'm a man, I'm a non-binary person, I'm a genderqueer person. What I would recommend is if you do this, test with your target group which kind of gender identities work and are accepted. Because first of all, in translation, you might lose a lot of things. Certain terminologies that work in one country might not work in another. There are regional specificities, and certain communities really embrace certain terms and other communities don't like them. So it's really something that you should pilot with your target group if you want to do this, because not everything works for everybody. But this will give you two kinds of information. And interestingly enough, for example, in studying something exquisitely biomedical like the side effects of a drug, I might want to know both, because I would like to know what are the biological aspects that can lead to the fact that my liver processes a drug differently. But I also would like to know, am I being taken seriously with my side effect because the doctor sees me as a woman and thinks that I'm complaining about something? So this is said in very simple terms, but it shows you that even for something like this, you might want to know both. Now, this is a historical artifact, which has been heavily criticized for all kinds of reasons. And I would say many of these can be embraced, but it is still the most widely used instrument to measure sex and gender roles and norms. Now, you should at least see it, and then you can decide what to do with it. It's the BEM Sexual Inventory, developed in the 70s. To investigate at the time sex roles, what we today would call gender roles. I think the one thing that's interesting about this, and also something in judging new developments, it's interesting to see how they deal with it. I think the one change that this instrument brought was in showing us that there's not two poles, so masculinity and femininity are not exclusive. There's not one axis with femininity at one end and masculinity at the other. What it did is it showed that all of us have a certain degree of identification with male traits, masculine traits, and feminine traits, kind of showing that we're all made up of different, personality traits and all kinds of different ways of dealing with the world. This is what it did. There are a lot of questions about its applicability in the world today, about its regional applicability, and the fact if it is actually measuring gender at all. Nevertheless, it was an attempt to do so, and there are several attempts that go in that direction. And still today, there are discussions about how do we move on from this? What are the best ways to measure this? Londa has shown us an approach before in kind of picking up different variables that can allow us to measure also gender norms and gender roles. It's an ongoing discussion, and I don't think we are at the end of it yet. It's still a developing process. Gender relation is the third dimension I talked about. Gender relations can happen in the private and in the public. In the private, it's really in your relationship, whichever relationship you have. How do you negotiate, for example, different duties? Who cleans the house? Who stays at home if the kids are sick? Who gets to have a career? But also in your professional environment, for example, if you have to negotiate your salary, in how far does gender and gender expectation affect the way you will be able to do that? The one thing I would like to show here, and I think is important that you take home, is if you want to measure gender equality, don't just ask people if their relationship is gender equal, because this is a study done in Sweden, and depending on what the general idea is in a certain country, so is it a country that praises gender equality or not, you will have a strong social desirability bias. So if you live in a country where it is good to live in a gender equal relationship, people are more inclined to say, yes, of course my relationship is equal. But then if you actually ask them to fill out a detailed questionnaire asking them about how many hours of unpaid work do they actually do, how many hours do they go to work, what happens if the kid has to go to a pediatrician, what happens if a relative is sick, so you actually break that down into practical steps, you will see, as you can see here, that the bars are not quite the same height. So that's just to say, if you want to investigate that, for example, it's always quite important and also interesting to see what people say themselves and how the reality of the divided hours looks like. As I said before, we're living in a time where people start to develop all kinds of instruments. This is an example of an attempt developed in 2015 from Louis Pilote in Canada, and with all the developments and questions to this index, it was definitely a moment of reinvigoration of the development of ways to measure gender in biomedicine. So what this index does, it tries to bring together different domains. And what you can see here is you have your BAM sexual inventory to measure the gender norms. You have these relational questions, for example, how many hours do you spend doing housework? Who's the primary earner in the home? So what you're seeing, this is an attempt to bring together different dimensions. And what it will give you is the probability between 0 and 100% to be a woman. Now, I told you before what the BAM sexual inventory did, which was actually breaking this up, that you cannot be 0 and 100%. So what we do here, and that might be one of the criticisms to this, is we take a step back, because we go from showing that individuals can have all kinds of different traits to one axis again. And the problem I might have as a clinician with this is, what do I do if I find somebody who's 60%? So what does that mean for me? How do I handle this now? What's the next step? So although this is an important step towards thinking about how can we operationalize gender, it also shows how difficult it is and how many thoughts have to go into this in order to not make it something that just perpetuates stereotypes, I would say. Now, we've seen the slide before from Vera Regitz-Zagorsek. I think this is a nice evolution of that slide as well, which has been published in the Lancet special edition about gender, which was published in 2019. It was an entire edition about how gender and health interact, with many quite interesting contributions that also offered a lot of theory. And this is pretty much a summary, but I think visually quite well done, of what I've told you before and what you've seen also in the slide that Londa showed at the beginning of her talk. Here we start with a baby with its sex attributes, genes, genitalia, gonads. And then what we see is that as humans, we don't live in a vacuum. We actually grow up in a society which has gender norms and distributions of power that are unequal due to these. And we start at the family level, it goes on at the community level, institution level, and the structure and policies. This leads to inequalities in our social systems, which are not solely connected to sex and gender, but actually interact, as we've heard before, with these other dimensions. We've already heard about intersectionality before. What it does is, in practice, it changes, it modifies, and potentially hampers our access to healthcare. and the ability, for example, to lead a healthy life. And this happens, first of all, at the individual basis, but then if we look at it from a broader perspective, it actually affects entire groups in the population that then have to bear the brunt of inequities in access to healthcare. So although in medicine we like to separate these two, in reality, it is quite difficult to disentangle what is sex and what is gender, because as we see here, they do influence each other throughout our lifespan. And so this is something to keep in mind. Now, let's move on to the more practical side of it. So what can possibly go wrong if you don't do it? It's a bit of like the convincing at the end. I've told you a bit of how you could do it, but what can go wrong if you don't do it? Now, this first one I will not describe anymore, but I knew that Londa would talk about this. I thought the slides should stay in because this is the one connected to, well, the eureka moment of realizing that researchers themselves can have an effect on the behavior of animals. And I think this is a really important example showing us how reproducibility can be affected by sex-specific factors that we simply didn't know about. So the first risk is losing reproducibility because we haven't looked, because we haven't thought about it. And so this is probably the first step. Now, the second one is an underestimation of hormonal effects. I talked about hormones before, and I also said that it's not just important to look at hormones. When we look at secondary sexual characteristics, these hormones actually affect pretty much all cells in our bodies. And this is a quite interesting study from the Netherlands where they looked at transcriptional profiles and protein profiles in individuals with depression and anxiety. And what they found was that depending on the hormonal state, these patterns were quite different. And what you see here is you have a group of males, so these are high in testosterone. Then what you see here is that really the different groups in the follicular phase, luteal phase, and postmenopausal, they kind of scatter together, so there's not a huge difference. But then what we have here is actually the group on oral contraception, which is something we should ask routinely everybody that we see, but in practice this doesn't happen, and a lot of times it's not factored into our analysis. And what this really shows is that here the oral contraception, one could say, okay, but this mimics what we see in the follicular and luteal phase, does in fact show a completely different pattern. If it is because it's a synthetic hormone, we don't know, but in principle, it generates another group of analysis, which we wouldn't have known how to identify if we hadn't looked for that, because we would have just found another group here. We wouldn't been able to explain why their proteome looked different. This is probably the best, the most well-known example, and probably the best way to exemplify why it's important to look at sex and gender, because if we don't, we delay diagnosis. And we usually delay diagnosis in the individuals that don't correspond to the stereotype I have of the disease. So if I think that cardiovascular disease is a disease of an elderly man, most likely everybody that is not that elderly man will be diagnosed later because we don't immediately think about it. If I think that osteoporosis is the typical disease of the postmenopausal women, men who are over 60 or 70 are not screened because as a society we still don't think it's relevant, and we find out once grandpa breaks its leg. So it is really something that has to do with the images that we use when we study. And of course, there is an epidemiological trend and there are epidemiological explanations which are important to take into consideration. But if they don't work the first or second time, I might have to think about something different. And this is still not happening. And that goes, examples here are, for example, bladder cancer. This is really a quite clear example when women go to the doctor and will say, okay, I found blood in my urine. The first thing we think about is probably urinary tract infection. And epidemiologically, we're probably right. But if they're after the second course of antibiotic, still nothing is happening and she's coming back again, we might want to have to think about different explanations here. When it comes to asthma, for example, that's a typical example where the symptoms are much more common. The typical symptoms are much more common in boys in this case. So the typical wheezing we associate with asthma is actually very common in young boys. Young girls a lot of times have dry cough at night and they don't have typical wheezing, so they're diagnosed later. As I said before, osteoporosis and autoimmune diseases are both perceived as typical female diseases, which leads to the fact that lupus, for example, is diagnosed much later in men, especially because they don't have the typical symptoms that are visible. For example, malar rash, which is a redding of the cheeks. Male patients with lupus usually don't have that. And osteoporosis, as I said, it affects 30 to 40% of men over 70. And although the professional societies recommend screening for it, we still don't do it systematically. This is one example, well, that it really shows also our personal bias as physicians. It's a study from Israel looking at patients with multiple sclerosis. And what they found was when they asked these patients, who did you see as specialists before you actually got the diagnosis of multiple sclerosis? Men are much more likely to have been referred to an orthopedic surgeon at a certain moment of their trajectory as patients. And women are much more likely to have seen a psychiatrist, while men usually are not sent to the psychiatrist. Now, my last two examples, if I haven't convinced you by now, well, what we really want to know when we investigate pharmaceutical options is if they're effective in women and men, and if we do see difference in side effects. This is another historical slide that I'm showing you. It's the DIG study for the safety of digitalis, which was done in the 90s. You see here, published in 97 in the New England. Here, the first question that was asked in the trial was if digoxin was as safe as placebo, and you see two perfectly aligned lines, so it seems to be really safe. What then happened is that digoxin was given to everybody, women, men, non-binary people. At the time, we didn't call non-binary people. And what happened is that we saw a dramatic increase in side effects, and this was mostly in the female patients. So 5 years later, this data that we saw here that showed us that the drug is safe was reanalyzed, in this case divided into female and male patients. And what you can see here is that digoxin is actually digoxin is actually more effective for survival in men than placebo. But if we look at the women at this concentration, digoxin is worse than placebo. Why did we not see that in the figure before? Because only about 25% of the people included in the trial were female patients. And so statistically, once we threw everything in one big pool, we could not see these differences anymore. So this is probably one of the most striking examples of why we should disaggregate our data in trials. Does it routinely happen? Well, that was 97. This is 2021. I would say for me and for most people working in the field of sex and gender differences in health, COVID has been quite an experience because it was the first time that we didn't have to go everywhere and say, well, maybe we should look at sex differences, because probably we had an overmortality in men initially. But the fact is, in general, there was a lot of discussion about potential effects of sex and gender on the disease. So together with colleagues in Denmark, we looked at trials registered, COVID-19 trials registered in the clinicaltrials.gov database between 2020 and January 2021. And what it showed in the year 2021 was that only about 1 in 5 specifically paid attention to sex and gender upon recruitment, and only about 1 in 20 actually reported the intention to consider sex and gender upon analysis. Now, not all of these trials ended, not all of these were actually conducted, so not all of these trials that are initially registered will see a publication at the end. So we looked at the trials, the pharmacological trials that were actually published in January 2021, and yes, the situation is a bit better, but we only moved from 1 in 20 studies planning to look at sex and gender to 1 in 5 studies actually offering some sort of disaggregated analysis. So what I showed you before here is still not the standard when we analyze our trials, although it seems to be quite simple to do because we actually do have the data. Now, the last one, and this is my last point, what is also interesting, I would say, is to look into the different impacts of sex and gender using available data, because for a lot of these questions, we might have pointers towards sex, the impact of sex and gender, but we really don't look at them. And this is something we did with oncologists and our colleagues in Tilburg. So we looked at a large cohort of more than 5,000 cancer patients, and these are long-term survivors. So these are people that have been clinically cancer-free for at least 5 years, so 5 to 10 years in most types of cancers. And we looked at different types of cancers. And what we wanted to know is, are there differences? So first of all, we did what people usually do, is we looked at sex differences in these symptoms, and we did indeed find quite predictable differences in symptoms. But then we looked at quality of life, and here we approached it slightly differently than what is usually done. Now, usually when you look at studies in quality of life, you pretty much always find that women do worse, because what happens is the female and the male patients in this case are compared, and what you usually find is the female patients do worse. What rarely happens is using a control group of the general population that doesn't have the disease and factor that in. In this case, we were lucky because we had a control group of the Dutch population in this case, which was cancer-free. So these were just individuals in the community. And what is important to know is that if you look at the general population and their quality of life, you will also see this pattern of female individuals potentially doing worse. So it is a trend that you might also find in the general population. So if you factor that in the analysis, what you actually find is that the worst quality of life in the female patients is not recapitulated. So what we found here was actually, especially when it came to the loss of role functioning and social functioning, and if you think back about the gender dimensions I was talking before, role is an essential aspect of this. Social interaction is an essential aspect of this if you want to look at the relations. These two men were doing much worse. And it was something that was quite surprising for our colleagues. And then once they went back, they said, well, this might explain some of the things we do. And it also correlates a bit with this, for example, an increase in depression that we saw in the male patients. So interestingly enough, this might be a pointer with data that was not designed to investigate gender specifically towards a role that goes beyond biological sex and that actually has a clinical impact. Because if I know that in advance, in these people living with a chronic disease, this is something I can address. So the change in role, the change in the way you will be handling the disease, the change in potentially your work ability is something that you can accompany. And this could potentially really have an impact on the quality of life of these people. Now, and with that, I just want to give some last remarks. What could you do? So after everything I've told you, what could you do tomorrow to do things in a more sex and gender sensitive way? Well, first of all, please know what your samples are. As I said before, do you know the sex of your samples? Do you know where these tissues are coming from? If you work with animals, do you know how they interact, what you're doing with them? I would say include at least both sexes. And if you want to investigate gender, think about what it is that you're doing. I think this is really the first and relevant step is what is it that you're measuring and what do you need for your analysis? Do you need to know about gender identity? Do you need to know about norms and roles? And how could you possibly investigate that? Then I would recommend consulting an expert. Londa and myself are talking today, but there's a lot of people out there that are actually experts in this field, in the different disciplines. Go find them. They can help you in setting these things up so you don't have to start from zero. And although people frequently think it's just comparing females and males and I'm done, it's much more complex than that if you really want to do it properly and find out things that actually matter for your patients. Disaggregating data should be mandatory. As I showed you before, we usually know who we included in the studies. You usually know if the patients are female or male. Just the analysis doesn't necessarily happen or is not made available. You should always stratify by sex, if possible, by gender, depending on whether you have these variables. Apparently, reporting is also not something that happens, even if these analyses are done. And some colleagues will tell me that they did them, we don't find them in the paper. Even if you don't want to put them in the main paper, put them in the supplementary files. We need this information to make clinical decisions for meta-analysis, so it's really important to have it. And of course, the last step is please share this information. Londa has showed you a lot of resources, the Gender Innovation website. You have your own resources that you're developing. Please share those with your colleagues. And with that, I thank you very much. And of course, we're looking forward to the discussion.
Thank you, Sabine Oertelt-Prigione, for this very, very interesting talk. I should remind our audience that there is a Q&A section where you can put your questions. And I think we have a few questions. So I will read now the questions for our experts.
Could I answer the question, the very nice question about the transgender?
Sure. Sure.
So I just want to quickly, Sabine, so first of all, I want to say what a pleasure it is to work with Sabine. About 5 years ago, I snatched her up to be a co-director of Gendered Innovations. because I mean, I don't need to say how knowledgeable and wonderful she is. But okay, so Sabine addressed this a little bit, but I wanted to come back to the question of transgender and the two-step process. So I presented this at NIH. It's not my work, but I think it's a very good way here. So this is about the same as Sabine. And I wanted to say that in our paper on gender-related variables for health research, we did look at transgender, but we couldn't report on it because we had 4,000 participants answering our questionnaire and only 2 came up as transgender. So we needed, more people. So anyway, I like this, this is exactly what Sabine said. What is your biological sex? And then for gender, there are these questions, this is, again, as Sabine emphasized, only gender identity, but it has transgender. And if you click one of these, you then get sent to this next page, which really goes into some depth of more specifically about your gender identity. So, and Stanford has recently hired our medical school, 2 new experts in gender medicine, which is very necessary. And I had one of them come and speak in my class. He's completely a riot. It was really fun. He made it fun, and it was super interesting for the, for the students, the undergraduates. So people are increasingly taking transgender very seriously and must. So I just wanted to comment on that.
Thank you very much, Londa. Yeah, in fact, I think in both presentations, you gave plenty of very, very interesting information and tools for our research community. I should remind we are a community of practice of 20 biomedical research centers trying to push forward our agenda in Catalonia. This community of practice of 20 researchers, I think most of the participants have a research profile. So I'm very, very sure that your presentations were extremely useful for them, either in the different phases of the research cycle. So I'm gonna go through the questions. So the first question is from Harvey Evans and says, Londa, what tactics do, so this is the, what tactics do you use considering that Stanford hasn't included the information in the curriculum? We are a long way behind. Any tips? I think, Londa, do you want to answer this?
I would be happy to answer, and I think Sabine should probably answer because she was part of the Charité group that really had some success. So at Stanford, of course, we've had some success, but at Stanford, everything is determined by the professor. You may not, no one tells a professor what to teach or not to teach. So we have established, my colleague Marcia Stefanik here has established a Center for Sex Difference Research. And now this is quite clever. She gives out seed grants. She gives grants, that are $25,000 to $50,000, not a lot of money in our context. And specifically to take any research you are doing and include sex or gender in it. So if you have done something, and so that allows the professor or the postdoc or the graduate student to discover for themselves the importance of these dimensions. And then the professor, I think, would include it in their lectures. So it's kind of a long about way, but we had one lab where the graduate student found that the main project of that lab was completely wrong once you looked at sex. And this brought around, your middle-aged kind of male lab director, famous person. So, and this graduate student is going to have a glorious career, of course. So that's the way we've done it. We've done it with carrots by offering these seed grants. And she to fund that, she asks each department in the medical school to contribute some money. And for them, it's kind of nothing. So that's been quite successful, and it brings about permanent change. But I think we should ask Sabine, because she was part of this Charité group that had some great success, I believe.
Yeah, I think it, well, that's a bit of what I meant with the content and the context before. I think you can have very good intentions, but if your organization is resistant or there is no window of opportunity, you will have a really hard time. And that's at least my experience we managed to do it at Charité at the time, but I work at 2 organizations right now in very different moments. And my experience is you need some kind of window of opportunity. So at the time when we did it at Charité, what happened was there was a transition period in Germany when most of the medical curricula, which were quite, I won't say ancient, but they had a very, well, I would say a very non-patient oriented structure in the first few years. And then what happened is we transitioned to modular curricula, which is what most of Europe does right now, where the new students try to, well, we try to put them in contact with patients as soon as possible. And we tend to teach around systems or organs, and everybody comes together to talk about that rather than having the linear course that we used to have. And about 10, 12 years ago, Charité was in that transition process. So that meant developing a completely new curriculum. And that, of course, gave us the opportunity to bring in some new content. So because what happened was that every year is divided into, depending which university you work in, 4 to 6 modules. And all of these modules have to be planned. And once you plan these modules, you give opportunity to everybody who somehow feels involved in that module to contribute and propose lectures, seminars, whatever teaching format you would like to do. That doesn't mean that it's easy. It doesn't mean that everybody will accept it, but it is a window of opportunity for redesign, and that allows you to bring in some new topics. So this is how we did it at Charité, because otherwise it would have been quite difficult. Until then, we had an elective course, so we had that running for a while, but we didn't manage to bring it into mandatory teaching. Now, the situation of the 2 universities I work in right now is quite different. So in the Netherlands, there is a certain openness to it, but the curriculum is established. So although people are interested in it, it's extremely difficult to get new materials in. So the way we're going here is really, we do the summer school, we do the elective, and then we will move into putting more mandatory teaching in the curriculum. Although what I can say is there's a certain openness, so at least of some colleagues. So we manage, and this is always the question, how do you do this kind of sandwich? So ideally you would like to have me or a person in my position come in and talk about the topic, but then what you want to do is you actually want to mainstream it. So you would like to have the gastroenterologist, the oncologist, to talk about sex differences when they talk about their favorite tumor. So it is really put it into whatever is happening, and that's the most complicated part. In Bielefeld, on the other hand, I have a very specific situation. This is a new medical faculty that's built up from the ground. That's also what prompted me to actually accept the job. Otherwise, I wouldn't have been doing it. But it is a unique opportunity. We have a female dean. She really supports the topic, and they set out saying that they want to build a curriculum that includes sex and gender sensitivity. So that means that on the one hand side, I have institutional support in trying to include that, what means that we're now planning the 3rd semester, and we already have 4 or 5 classes that we teach. And in addition to that, I have several colleagues that are teaching it in their in whatever their specific specialty is. However, it doesn't mean that everybody has an open mind and wants to do it. So the whole process, the more complicated part of actually convincing your colleagues who are not experts in that field to include it, this process we still have to go through. So I think that's really an organizational change process where you have to reach a certain critical mass that you have to build over time. You have to build the credibility. You have to find allies. You have to show that it's actually a scientific topic. You have to see what their understanding is of the topic. So how can I connect to them? Are these basic researchers? Are these clinical researchers? Is it people coming in from a public health perspective? They speak somewhat different languages, as you know. We manage to work together, but it is a process of finding a common ground. So that I think you still have to go through, even in the most ideal, if you want, and welcoming conditions. So my experience is you find a window of opportunity, or you're given a window of opportunity, or you have to work really long to generate the windows of opportunity. And it takes really a lot of community building, network building, establishing this. And this is really what I could say to the topic from my experiences in the different medical faculties.
But so we have, there's a summit on this, on medical education and integrating sex and gender. I think that's also international, but it's in the US from maybe every 4 years or something like that. And lots of suggestions have come from that group. Like put it on the licensing exam, put these questions, this topic on licensing exams. And I think people in medicine have to get recertified in things, put it in those courses that do the recertification. So there are structural things you can do in addition to working really hard at your own medical school.
Yeah. So
and I think in Germany, doesn't the new government have a platform saying that all medical schools must teach this? I mean, make them hold their feet to the fire.
That's a political statement that happened before the war started. So let's just say that. And then we decided that we need to put 100 billion into rebuilding.
No, I understand.
So let's put it like, but in principle, yes. And it's also true what you said. So the relevant things that we saw at Charité and I'm seeing in this other curricula, you have to test it. If it's not in the tests, in the exams, at the end of the modules, if it's not in the certification, it gets lost. So that's an essential aspect in developing this. What is positive in that respect is in the German framework, we redeveloped the teaching goals, the training goals for the whole medical curriculum. And a lot of those are now include a passage on sex and gender. So the fact that it should be considered. And we're also working on the questions for the certification and recertification. Mm-hmm. However, what you said before that, at Stanford's professors say, I teach what I want to teach. We have that in Germany too. It's like liberty of, it's a big thing that especially people who are resistant to the topic somehow seem to embrace very strongly. So yes, you can try to build all of this and it is helping. And I think it's helping in the long run because you teach it to the new generation. They will pick it up and so forth. But there are also individuals who, regardless of all of these structural aspects that are really as much as we can do top down, are still resistant. So let's just say that those still exist and will keep existing for a while.
Okay, thank you very much. There are lots of comments on people being very grateful for your presentation. So we'll skip this. And since we are running a little bit out of time, I think we will now let the next speaker to present the Catalan tool. And then the 3 questions that are left for you, Sabine and Londa, we will have hopefully 5 minutes to respond. So I will leave it after Maite, and let's see if in 5 minutes we can address the 3 questions that you have in the Q&A. Okay, so I'm going to present the next speaker. I should remark that, as I said before, this webinar is organized by the Community of Practice Hipàtia of Alexandria, and the work of this community is on one hand really on the topic of today, which is the introduction of gender and sex in research and biomedical research. But also, in these terms, since we have, and this is part of the strategic plan of the Department of Health of the government, the Community of Practice has created a tool that in a minute Maite Solans Domènech will present. So Maite Solans is currently a research leader at Aquas, where she is part of the Aquas group in charge of the assessment system of responsible evaluation, SARIS. She contributes to projects oriented to real-time impact evaluation and to responsible research and innovation. She participates in projects that promote RRI and social impact through evaluation, training, communication, and co-responsibility. She also participates in the Research Results Center, which renders accountability and transparency, disseminating the results of the biomedical research centers of Catalonia, and in the promotion of evaluative practices together with science policy bodies and funders of health research programs. Maite is the coordinator of the Community of Practice of Hipàtia of Alexandria that is organizing this webinar today. So the floor is for Maite.
Thank you, Paula. I will start to share my screen. Okay, I must say that I'm here presenting today the toolkit, but it's on behalf of a great number of people from different Catalan research centers who have been participating in the development and also reviewing it. And also that this toolkit could not have been developed without the support of the Health Department of La Generalitat and La Caixa Foundation. Just to begin, I must say that, I must say that the toolkit was developed on the basis of published resources for conducting sex and gender integration, which help us to identify points where sex and gender should be integrated and develop the first version of the toolkit. And later, we ask for feedback to different biomedical and health researchers and experts who assess the toolkit, if the toolkit was clear, useful, and complete according to their perspective, and give some recommendations for improvement and to create the final version. Very briefly, the idea of the toolkit is to help researchers in considering accounting for sex or gender in basic clinical health systems and population health studies, and basically is a checklist that captures each phase of the research process. So it's exclusively studying the content of the research, and it does not imply the context. It's divided in 4 sections: identify the problem, study designs and methods, analysis, and reporting and knowledge translation. And it's organized in 3 levels. First, there is a list of questions tackling the integration of sex and gender into research. Then there is a list of sub-questions with the idea to illustrate each question. And finally, you have the 3rd level with some examples or specificities, depending on the case. If we begin with the first section, the first thing you should do is to know if you will explore sex or gender difference. And as Londa and Sabine explained perfectly the concepts, I will not begin with the definitions, but what is clear is that we are talking about multidimensional concepts. That is, that it's not only the defining sex at birth or self-informed gender identity, but all the factors that are related with it. Also in this section, you find aspects related to the literature searches in order to find out what other researchers in your field have discovered about sex and gender and how they measure and account for them. And consider that no matter if sex or gender issues are not documented in the literature or nobody else is analyzing, this cannot be used as an excuse. And in any case, if you don't find more information, and as Sabine said, you can consult an expert in the different disciplines. So in this section also, it's the part when you have to think who will be benefit and who will be left out if we don't analyze sex and gender issues and its associated factors. And as an example, for example, now that all of us are using mobile phones with facial recognition, for example, facial recognition systems are not designed to recognize faces wearing makeup because nobody investigated about that. So that is a missed opportunity in investigation. The second section, it's about the study design and methods. So now that you will have clear about that there is a diversity, that there is some factors that are related, and that maybe we can find the difference in sex and gender variables, the next step is to think how we will incorporate this diversity in the study design, in the population target, in the recruitment of participants, or in the selection of study variables and recollection tools. And for example, some of the points that are included in the toolkit are about how do you consider this diversity in your inclusion or exclusion criteria, if you will need some specific recruitment to get equal numbers, Or, as Sabine told us, consider a two-step approach in surveying methods for asking participants to identify their biological sex and the current gender identity. Or, for example, if, as Londa, for example, explained us, sex animal and the sex of the researcher can interact. So if you consider these kind of aspects in your research. The fourth part, the third section, sorry, is the analysis and statistics part. And here is included how do you calculate your sample sizes if you are going to consider it that it can be these differences. And mainly it's about to stratify your analysis by sex and gender. For example, something that is very typical is that in publications, everybody presents in table 1, for example, your sample with difference by sex or gender, but then in the analysis, it's without stratification. So here what it's explicit is that you have to examine similarities between groups and variations within groups, and consider to adjust, for example, for possible intersecting and confounding factors to not overemphasize sex and gender difference. And the last section is about reporting and knowledge translation. And it has these two parts. One of the parts is about reporting with a sex-gender lens. For example, as Sabine says, report data in disaggregated format. Or Londa explained us that you have to include the negative results, or also discuss the influences of sex and genders in your findings, or discuss limitations of the data in relation to sex and gender issues, or use a gender-sensitive language in all the disseminations and communication activities. And also includes a part about the translation of this knowledge into the practice, incorporating the sex and gender diversity. That means if we try to maximize the adoption by diverse people. So maybe we have to customize our translations dynamic. For example, the content or the message or the products that can vary by sex or gender. So in conclusion, what the toolkit shows us is that we should think about what do you want to investigate, what is your outcomes you are looking, and which are the factors or confounders that can be relevant, and take this into account at all the stages of the research cycle. And in any case, as Londa and Sabine says, you can consult an expert. And also about the toolkit, I would like to add that we recognize that the toolkit do not necessarily resolve all the challenges of sex and gender integration in biomedical and health research, because the possibilities are infinity. As Londa showed us in the website, for example, of the gendered innovations, you can find case studies and methods about a specific research and maybe you can find there the aspects that typically you want to search. But we think that the toolkit, it provides a practical guide for helping researchers to prioritize the incorporation of sex and gender issues in order to improve, as Sabine says, the value, the applicability, and the quality of the research. And we think that it's a good way to begin to adopt the integration of sex and gender in biomedical and health research as a standard practice. And finally, just to say that the toolkit is published in the ACAS website in the research area. You can find it in an online format and also in PDF format. It's in Catalan and in English. And a part of the toolkit, it includes few examples from different areas and health issues that show why it's important to consider sex and gender in biomedical and health research, and also key definitions and concepts that can be a basic help in integrating sex and gender into health research. And that's all.
Thank you very much, Maite, for this excellent presentation. Important to notice this toolkit is in Catalan and in English, and it's in PDF, but also in interactive in the web page of Aquas. And it will be an available tool for the funding scheme of the Department of Health of the Government of Catalonia, the PERIS program. So the researchers that want to apply for funding will have this tool available and in order to incorporate gender and sex in their proposals, but also will be available for the 20 research centers that want to apply to any other funding scheme or wanting to publish in a journal. So let's go. I think we have 15 minutes and 5 questions. Very interesting questions, both for Londa and Sabine. So I will start from so first is a congratulations to Londa, saying any suggestions regarding qualitative methods for analyzing gender norms and relations? Do you feel that mixed gender focal groups provide insights or reinforce certain biases? Londa, do you think we can respond to this now, or should I read all the questions and then you prioritize, you and Sabine? Okay, so I go through all the questions. So the second question is, I wonder if everybody is able to answer the question about what is your gender with all these complex answers. I am thinking specifically about monoparental individuals or single living who come to act and have the role of both binary genders. And finally, you do not know anymore how do you consider yourself regarding norms and roles and gender. I read the third question. Fantastic work, Londa and Sabine. Thank you very much for the resources. As an independent equity researcher, our team has been working closely in sex reporting in primary studies, specifically in Cochrane reviews. We found that whenever women were in dominant author positions, first or last, this contributed to a higher 2 times more reporting on sex and more secondary analysis too. Our second work was how funding for COVID-19 research was distributed by gender or award recipients, showing that there were 80% versus 20% man-women recipients. Therefore, what are your thoughts on how can we actually move forward in this field in predominantly men are receiving funding, at least biomedical research, and men as authors don't ensure a gender lens in primary research. I go to the last question. Thank you, Londa and Sabine, for the exceptional presentations. I found this to be a very complex subject, and I was wondering, in your opinion, how do you think society evolution, for example, ever-changing gender roles and interactions, will affect how we incorporate these variants? For example, will age as a generational context factor be taken into consideration? So, very a variety of questions. Londa, you want to give a first go, and then Sabine, you can also respond to a selection of these questions.
Yeah, so I wanted to first say something about this BEM index that Sabine was talking about. It was developed at Stanford in 1974. I don't use it because that population of students was very white, very privileged, and very athletic, because we send people to the Olympics all the time. So how can they represent human beings? So I don't use it, but it's an interesting thing. I wanted to say that, yes, we found the same thing of the women in first and last authorship. Matthias Nielsen and I did a study of 1.5 medical articles, and we found that if there were more women authors, there was more attention to sex and gender analysis, which means it's more excellent research, right? That's the point. So the stuff that doesn't include sex and gender analysis should not be published. So maybe this would damp down the publication of people who don't include women on their team. I don't know. And then the other thing about the funding, we in the United States, I would encourage you all in Catalan to look very carefully at your funding agencies. NIH many times has looked at who is funded. So at NIH, it's equal numbers of men and women are funded now after many years of checking it out. And now we're looking at underrepresented groups. So is the funding, these are public funding agencies. So the agencies have the right to make the funding equal. So that's all I have to say. It's kind of a governmental issue here. And I'll let Sabine go on with other answers or questions.
Yes, so I wouldn't say anything to the authorship because I think you've done amazing work on that. And I love to cite that study because it is really great to show how clear it is, and 1.5 million paper can already be beaten. I would pick up the qualitative question actually, because we have been trying to do that in a project where we're looking at people with Parkinson's disease. So we have a project going on right now. It's actually the PhD project of one of my students. And what we're doing is we looked at how can we measure gender in quantitative terms. And what we did is we actually didn't build an index. We separated it out. We looked at identity and expression and norms and so forth. We did a qualitative part where we actually asked people living with Parkinson's how they felt gender impacted their lives, which was quite interesting because most of them initially looked at us really puzzled and were like, well, what do you mean? So that was really interesting study, and it also showed us how different people attribute different value to gender and health. And we're going to do a design part in that study as well. But what it shows basically, so we're done with the quantitative part, which is going to be published now, and the qualitative part we're almost ready to submit, and we're going to do the design study. And what we're seeing, it's kind of a triangulation approach, because we're really getting completely different information about complementary information out of these different areas of study. And I would say it's a shame that in medicine, a lot of times we're really just focused on the quantitative part, because the information we're getting is broad, but it's not deep. And especially if you study a subject like sex and gender, in a way, it's an ideal subject where you actually need both. And to really understand, and especially also when it comes, and that connects a little bit to the last question, to the changing gender norms and gender roles, and how that affects people, and how that affects also what we can measure in time and space, and how to do that. I think you really need, in most of these studies, especially if you measure gender, you need a qualitative approach, first of all, to understand your target group. So I worked with oncologists. I showed a little bit about that work. We're working with people with Parkinson's. We work in the cardiovascular field. These are all different groups of patients that have different histories, that live in different environments. They have different problems they're dealing with. And that is still saying that in this case, most of these groups are in the Netherlands, and they're mostly Dutch natives, white, relatively middle to higher social status. So they're quite homogeneous, and still we're seeing these differences. So let alone when we take more diverse populations, what we can do in some other studies, how much diversity you're going to find. So I think it is really important before you do that quantitative part to also understand how people, what do they attribute to gender, how important it is, what they understand when it comes to gender. And I think this is really essential also in moving forward in trying to develop more questionnaires and more ways to measure this in quantitative terms. We really need that kind of background information. And that also means that we need to value in the health care research field, not so much in public health, but really in the biomedical field, value the input of this kind of qualitative work much more, because it does make our quantitative work better, but it's still something that is not always being perceived that way, while it is quite enriching, I would say.
And I can take this last question about evolving gender norms. I hope so. I hope gender changes. I don't know, when my children were small, that's like 30 years ago, I kept saying, I'm raising them gender free. So I don't know what our goal is. Gender free? I mean, do we lose all the richness of the variety of gender? But in any case, the question there was about age, and we emphasize all the time, you have to look at age, you know, and we emphasize now in the US more and more, you have to look at ethnicity. So I have just designed intersectional design cards. This is for product design, but I think it's relevant. It's relevant to medical devices. It's relevant to any of these things. And we have 12 intersectional factors and none are privileged. So here in this seminar and in medicine, and we must privilege sex and gender, but I can see privileging sex because sex is important, but gender is one social factor among many, among 12, 50, 100 others. So it's not clear to me that gender is the thing that should always be privileged. I mean, of course, I've spent many years studying this, but nonetheless, we talk about age, disability is a big issue, ethnicity. We even talk about family configuration, which was one of these questions here. We don't all have the same type of families. And, we talk about geographic location. Even in the US, if you're on the West Coast, all of the gender and ethnicity is different. It's Asian is the ethnicity on the West Coast. If you're on the East Coast, it is more African-American. And geographic location, if you're in the Netherlands, if you're in Catalonia, wherever you are, it's different. So we need to take this intersectional approach that opens it up to many social factors. But then when you're doing research, you can only do so many. So you have to decide for your particular, so I usually list 50 intersectional factors, but then I say, you have to decide, we all start our research broadly, and then we narrow it to the question we want to answer. So you have to decide for your particular project and research, what are the most important factors that you need to consider so that you can actually do something.
Thank you very much, Londa. Sabine, do you want to add anything else?
I would say that's a perfect conclusion, because I think that's really the message is really, you need to make decisions, but you should know what you're trying to investigate, and then you need to make decisions about that. I think if we implement that, we're already quite some steps further than where we are today. So I would totally subscribe to that.
Okay, so thank you very, very much. I think this was a fantastic talk. I think, this talk was recorded, so, and we will have it, and we can see it again and again, as many times as we need it as a community. Really, today this webinar is a milestone in our agenda on gender equality and female leadership. I should remind the audience that this is just one step, and that there will be more actions of this community of practice, and at the end of the year we will organize a gender summit. So thank you very much, Londa Schiebinger, Sabine Oertelt-Prigione, and Maite Solans for the very, very, very interesting presentations.
Yes, thank you. It was fun.
Thank you again for the invitation.
Thank you. Okay. Bye-bye.
Okay. Bye-bye.
Bye.